All right, well, good evening and welcome. I'm Dr. David Klein, who's losing my voice today. I'm the Chief Executive Officer of MarinHealth, and I would just want to take a moment to thank you all for taking time out of your busy lives to come hear about something that I think is extremely important, and that is skin cancer. So I think it's probably affected each and every one of us in this room. I can tell you that it's affected me. I grew up in an era where we never used sunscreen, and we did use sunscreen. We called it mineral oil, and we would slap it on our heads and our bodies. And years later, I'm paying the price, and I'm sure many of you have done that. And if you think about what our weather's been like here in Marin on a day like today with the heat that we've been seeing, it's a perfect day to make sure your heads are covered. I wasn't blessed with hair on the top of my head, so I pay the price more than once, but I think you're going to really enjoy tonight's talk. So skin cancer is the most common cancer in America. I think probably many of you know that, and I know Dr. Gogia is going to talk a little bit about the prevalence. More than 5 million cases are diagnosed here in this country, in the U.S. 5 million. That is an amazing number. And in hopes of getting diagnosed, it is one of the most diagnosable cancers and treated. So it's important that we prevent and have early diagnosis, and the treatment options are really quite great. A couple housekeeping items before I introduce Dr. Gogia. Obviously, we have dinner. Please feel free to grab some whenever you have a moment. It looks like it looks pretty good. I may actually have some myself. The bathrooms are out this door and to the right if you need to use the restroom. And at the conclusion of Dr. Gogia's talk, we're going to have some time for a Q&A. And I'll be available as well if there's any administrative or hospital-related questions. We don't want to go too far off track, but I want to make myself available as well as Dr. Gogia. So we're really very fortunate tonight to have Dr. Gogia, who's a board-certified dermatologist, and he's been in this community for quite some time, and I think he probably has treated some of you that are here in this room. He's fellowship-trained and board-certified in Mohs surgery. He'll explain what that is. I've had the opportunity to have Mohs surgery. It's a very precise way to remove cancers and not take too much skin and too much tissue, and I think we'll talk a little bit about that. He does specialize in skin cancer surgery and Mohs surgery and surgical technique that provides the highest cure rate for skin cancers with the best cosmetic outcome. We certainly want, when we're dealing mostly with our faces, and noses and heads and all that, we certainly want to have a good cosmetic result. And he brings and you'll see this as soon as he steps up. He brings a great passion for helping patients address their skin concerns with prevention and evidence-based treatment. So, without further ado, Dr. Gogia.
Thank you. All right, can you guys hear me okay? Great. Well, thank you so much for having me. It's really a pleasure to speak with each of you. I'm going to talk about a number of things tonight. I'm going to clarify one thing because it's a conversation that I have every day. You can pronounce my name however you'd like, but it's actually Gogia. And my staff will often say it incorrectly as well. That's okay. Anything that sort of starts with a G, I will respond to. And you can call me really anything. Ravi is what everyone calls me. My first name is Ravinder. Nobody calls me that in my whole life, but the last name is pronounced Gogia. I'm going to talk to you about skin cancer. Many of you, I can tell, know a little bit about skin cancer. Some of you, if you're patients of mine, have heard some of this talk before because I do try to educate our patients as we go through our clinic days. But we're going to start with talking a little bit about me, a little bit about my practice. We're going to talk about MarinHealth Dermatology. Many of you might know that we joined MarinHealth earlier this year. It's been great for us. I think it's been good for the community to have a closer alliance between the dermatologists and your primary care doctors and your subspecialists overall. We're going to talk about skin cancer. Obviously, that's why you're here, some skin cancer statistics. We're going to talk about what to look out for. And then we're going to talk specifically about 4 different types of skin cancers: basal cell carcinomas, squamous cell carcinomas, melanomas, and something that's been in the news recently, which is Merkel cell carcinoma, which killed Jimmy Buffett. So we'll just talk briefly about that. We're going to talk about treatment of skin cancers, and then we're going to talk about prevention of skin cancers. So that's a lot of stuff to cover. It's a mini dermatology residency. It is not going to be exhaustive, but I do want you to leave here feeling like you understand what the most common types of skin cancers are, what we can do for those things, and when you should really say, like, hey, I think I need to see my primary care doctor, I need to see a dermatologist to look at this spot. I'm happy to answer questions. I think we'll keep them until the end because I think it'll be a little bit more helpful that way in case I hit those topics as we go forward. This is a little bit about me. What does it mean to be a dermatologist? I was actually born and raised here in California, about a couple of hours away outside of Sacramento. I went to Stanford for undergrad, and then I was fortunate to be at UCSF for medical school. I went out to Boston for my medicine internship and then came back to do my dermatology residency and my surgical fellowship at UCSF. So I've been in the area for most of my adult life, and I was very fortunate about 10 years ago for Amy Cobalter, who many of you guys know, who hired me out of fellowship to come be the Mohs surgeon and dermatologist in her group. So I have been in Marin practicing for more than 9 years. It is an amazing place to practice. I have been very, very fortunate, and I enjoy it quite a bit. I'm board certified in dermatology and in what's called now micrographic dermatologic surgery, but this is Mohs surgery essentially. And our practice is quite busy, and my practice in particular is very busy surgically. So we're doing more than 600 Mohs cases a year now. This is just that specialized form of skin cancer surgery. In fact, we passed 600 today, so we'll probably come close to 700 this year. I love doing it. I enjoy taking care of patients, and hopefully you'll see that. I will say that the most important thing for me, though, is this. This is who you will see me with in the community. This is my beautiful wife who works in San Francisco at one of the corporate banks, and these are my two kids, my daughter and my son. I am obsessed with them. You will hear me talk about them if you see me in clinic. You will see pictures of them on the wall. I'll try not to bore you with stories about them, but they are super fun, and we live in Corte Madera, so you will see us around. Please say hi if you do. As a point of fact, I don't say hi to patients when I see them out because of HIPAA privacy rules, so don't feel like I'm ignoring you. I just don't do it as a baseline thing, but you are welcome to say hi. I'd love to say hi to you. But they are people you will see me with, and I am obsessed with them, as I said. Going back to the next thing, the MarinHealth Dermatology affiliation. So we were dermatology consultants of Marin. We are now MarinHealth Dermatology, but we still have this amazing group of dermatologists, Dr. Cobalter, who many of you know, Dr. Kohler, Dr. Howard, who is a pediatric dermatologist, Dr. Zetterson, and then Dr. Lin. All of them are amazing dermatologists. I feel very fortunate to work with them, and any of them may see you if you are needing to be seen in clinic. All right. So we're going to move forward now to the main bulk of this talk. And there she is, Dr. Cobalter entered in the back, as I promised. I just was showing you the pictures, but Dr. Cobalter is amazing. As I said, she hired me about 9 years ago, so I really appreciate that. All right, what is skin cancer? So I think the basic question here is, what is cancer overall? And cancer is an uncontrolled growth of cells. That's it, at baseline. And skin cancer, obviously, then is an uncontrolled growth of abnormal skin cells. And I think you know this, but what happens is that you get UV damage from sunlight, and it causes damage to the DNA, and you then have mutations that lead to this uncontrolled growth. So broadly speaking, cells have the ability to arrest their cell cycle, to only divide when they are supposed to only divide a certain amount of time. But when you end up with these mutations in the DNA, you lose those checkpoints, and these cells continue to grow. And they grow abnormally, so maybe they'll bleed a little bit more easily. They won't sort of heal properly. And that's basically what a skin cancer is. We're going to talk a lot more about this, of course. One of the interesting things is that people are constantly having mutations in their cells as they are dividing. And so you constantly have small mutations, even in the absence of UV light. But your body is actually quite good at identifying these atypical cells because your immune system is constantly surveilling your skin and your other organs to see if there are these collections of atypical cells, and if they exist, the body will kill them off until it can no longer do that. So if you imagine when patients or people have immune systems that are impaired, their development of cancer increases because their immune system, whose job it is to kill off bacteria and to fight viruses, but also to surveil the skin, is no longer able to do so. And we're going to talk about that in a little bit, but I want to put that out there that one of the reasons that patients get more skin cancer as they get older is that they have more sun exposure. That makes sense. You get older and every day you get some more sun. And one of the reasons that older patients have more skin cancer is that their immune system is less able to maintain the atypical cells and to make sure that they don't progress. All right, so these are some skin cancer statistics that Dr. Klein hit on. Most common cancer in the United States, 1 in 5 Americans will develop skin cancer in their lifetime. You know, said a different way, almost 10,000 people are being diagnosed each day with a type of skin cancer. One thing that we're seeing in Marin, of course, but you're seeing throughout the country, is that the incidence of skin cancer goes up. A lot of this is due to the fact that 30, 40 years ago, people were not using sunscreen. There's quite a delay from the time of skin cancer, or of sun damage, to the development of skin cancer. And so one of the encouraging signs is that while skin cancer development in every age group seems to be increasing, we are seeing at least some pullback in the younger patients developing melanoma, probably based on the fact that they have been better about wearing sunscreen. So I think there is something there about just being able to protect yourself from the sun. The numbers that Dr. Klein referenced, 5 million, you'll see 2 million, you might see 3 million. These are, no one has the exact numbers, but somewhere between 2 and 3 million basal cell and squamous cells diagnosed each year, and then another couple 100,000 melanomas. All right, so sounds pretty dire. It's not. These are very treatable types of skin cancer. This is a lot of text, and I apologize for that. But basically what we're saying here is everything about UV exposure is bad when it comes to skin cancer development, but what's particularly bad is lying in a tanning booth. So you have a significantly increased risk of developing melanoma, even with one episode in a tanning booth. If you have more than 5 blistering sunburns before the age of 20, you increase your melanoma risk by 80%. And the risk factors for all types of skin cancer, this is not a surprise for anyone. Skin that burns easily, redheads unfortunately have an increased risk, a lot of sun exposure. We talked about the weakened immune system, and then personal or family history of skin cancer. So a family history of any skin cancer, and we mean first degree relative here, increases your risk of skin cancer 4-fold, just based on that. So genetic predisposition to this type of skin cancer development is real. And then, of course, if you've had a skin cancer, your risk of having another skin cancer is higher. This has to do with everything that you might expect. You've already been genetically predisposed to developing skin cancer, so you can develop it somewhere else. You've had enough sun exposure to develop one skin cancer, so you have enough sun exposure to develop a different one. So melanoma survivors have an increased risk of developing another melanoma. Same idea. Skin cancer kind of begets skin cancer in that way. All right. As I said, it's a mini dermatology residency, so we're going to go through the structure of the skin. There's not really one screen I can point to, so I'm just going to point to one here, and then we can see. Maybe I'll come over here and try and do it. This right here is a slide that represents the tissue. This is actually what you'd look at under the microscope. These two are schematics of the layers of skin. Basically, I want you to see that there are 3 main layers of skin that we'll be talking about. There's an epidermis, there's a dermis, and then there's subcutaneous fat that's underneath there. In this top layer of skin, this dark blue or purple that you see here, that's called the epidermis. And basal cells represent the base layer of that top layer of skin. Squamous cells are made up of keratinocytes as well. That's sort of the rest of that area. And then melanocytes are interspersed between those keratinocytes. So I'm going to go through this again. Keratinocytes is a skin cell. Melanocytes are pigment-producing cells. And there's basically 1 melanocyte for every 36 or so skin cells. And that's just all that exists in the epidermis that's right there. Okay. We are going to come back to this idea of what's in the epidermis, because when we classify skin cancers, the presence of skin cancer in the epidermis alone is different from a skin cancer that exists in the epidermis and in the second layer of skin. Okay? All right, so the first one is basal cell carcinomas. Basal cell carcinomas are by far the most common type of skin cancer, definitely more than 1 million cases a year. And they have a classic appearance. This is what you'll read about in the textbooks. It's this first one here on the nose. It looks like a pearly papule, slightly translucent. It often bleeds with minimal trauma, continues to grow, and often has what are called arborizing vessels. And that really refers to, if you're looking at it under magnification, or in this case you can sort of see it, there's little red blood vessels that look like they're going over this bump. okay? In the second picture, it's a much more aggressive, much more advanced type of basal cell. And then over here on the ear, what you're seeing is what looks like an ulcer with sort of a pearly rim. These are words that we use, but basically none of this looks normal. So that's what I want you to take away from this, is that these do not look very normal. Okay. These are locally destructive skin cancers. They don't really spread to other parts of your body. Now, if you go look through the literature, you're going to see evidence that occasionally it does, but for all intents and purposes, basal cell carcinomas destroy the skin locally, but do not spread elsewhere. Now, local destruction does not mean that they're harmless. They are not benign. If you neglect a basal cell for long enough, it can destroy enough tissue to destroy some of the cartilage of the nose or of the ear. Or really neglected for a long period of time, aggressive basal cells can destroy into bone. These don't happen very often. They are very, very rare for that to happen, but basal cells are not benign lesions. They are skin cancers. They have that potential for continued uninterrupted growth. And they come in a variety of subtypes. So if anyone has ever seen me in clinic, and we're talking about Mohs surgery, you hear this speech that I give about how basal cells come in a variety of different subtypes, which refers to the architecture of the tumor under the microscope. These are descriptive terms that the pathologist gives us to help us understand how the tumor is growing, which gives us some insight into the relative aggressiveness of the tumor. What does it mean to be relatively aggressive, or to be aggressive because these things don't spread? Well, basically, some skin cancers are larger than they look. More aggressive patterns of basal cell have an increased risk of a tip of the iceberg phenomenon where what you see is not what you get. I have all sorts of terrible analogies to try and explain this, but I'm going to first show you what 3 different types of basal cell patterns are. There's no test at the end. You don't have to know this later. But this is called a superficial pattern. That's the first one. All of the atypical cells are budding from the undersurface of the top layer of skin. This is called a nodular pattern of basal cell, really large collections of atypical cells that can be anywhere, but often are in the second layer of skin and sometimes in the third layer of skin. And you kind of have to squint to see this, and that's the point. In the third one over here, this is called the morpheaform basal cell. This is the most aggressive pattern of basal cell. The thing I want you to take away from here is that this is hard. You can really easily see in the second picture what the atypical cells are. It is much more challenging in the third picture to see which one's normal and which ones are atypical, because these are fine wisps of atypical cells. Okay. Why does this matter? It really matters because when you make your decisions on how to treat skin cancers, you make it based on 3 factors. What the site is, where it is on the body, what the subtype is, what it looks like under the microscope, and what the size is. So if you come in to see Dr. Cobalt or you come in to see me in clinic, we're going to talk you through the options, and we're going to say, because of the anatomic site, we should do this. Or maybe because of the fact that it is an infiltrative pattern of basal cell, we should do something else. All right, now those terrible analogies that I was talking about, bear with me for a second here. The middle one is called a nodular basal cell. So nodular basal cells are large collections of atypical cells. I want to imagine that you have some beach balls, and you're going to make your bed. You're going to put the beach balls in your bed, and you're going to put a comforter over it. And then you're going to have someone come in, and you're going to be like, hey guys, what do you see on the bed? They're like, there's 2 big beach balls under the comforter. You can see exactly where those beach balls start and where they stop because the mass of the beach ball, or the mass of the nodular basal cell, is changing the surface of the skin. So much more likely in a nodular basal cell that what you see is sort of what you get. It can be bigger, but it's sort of the same. Now, instead of those beach balls, you're going to have marbles. And you're going to put marbles all over the bed, and you're going to put the comforter over it, and someone's going to come in and say, I don't even know what you're talking about. You just made your bed. But you need to get all the marbles out. So when we talk about Mohs surgery, we're talking about being able to evaluate the margins because we can't see the change on the top layer of skin. Similarly, with morpheaform basal cells, which I said are the most aggressive pattern, you really don't see where things start and stop when you just look at it clinically. All right, which brings us to our second most common type of skin cancer, which is a squamous cell carcinoma. This is made up also of skin cells or keratinocytes on the top layer of skin, as we talked about. But squamous cell carcinomas invade into the second layer as well. We'll talk about that in a second. These are 3 sort of classic examples of squamous cell carcinomas. You can see that some of these sort of overlap with what you saw in basal cell, but classically these are rough areas that are often tender, that don't heal. They can sometimes be really crusty and have a little bit of white crust on it. As I said, this is another type of skin cancer that's mostly locally destructive but has the potential to spread along nerves and can infrequently spread to lymph nodes and can result in death. So we put this in there because it can happen. It's very uncommon. The risk factors for this are those things that really would make sense to you. So really big skin cancers don't do very well. Very deeply invasive skin cancers don't do very well. Very atypical cells where they look just really weird, they don't do that well. Things that are spreading along nerves, and then especially patients who have immunosuppression from their organ transplant or some other problem. So if your immune system isn't helping you out, things can go a little bit worse. But on the whole, these are very treatable. The cure rates for this, for Mohs surgery, for example, for a squamous cell carcinoma, reach pretty close to 99%. And metastatic rates, depending on the papers you look at, could be up to 10%, but really I think in practice we would probably tell you it's less than 1% in the average. So it's not something that we see a lot. All right, that is a lot of information so far. I'm hoping that you guys are still engaged in this. We're going to talk about this one thing about an in situ versus an invasive squamous cell carcinoma. So I told you before that keratinocytes live in that top layer of skin. When the atypical cells are all limited to the top layer of skin, we call this an in situ carcinoma. Okay. When it is into the second layer of skin, we call this an invasive carcinoma. We see this again in melanomas. We'll talk about it again. But again, when we talked about how we make decisions about treatment, we make them based on these things: where they are in the skin, how deeply they go, that kind of thing. I mentioned this before, but basically UV radiation is the cause for most of these things. You can get them from smoking or from thermal burns or chronic ulcers. The things that really are problematic is immunosuppression. And I put this in there because it's probably relevant. Hydrochlorothiazide is one of the most commonly used medications for blood pressure control, and there are some papers out over the last 5 years or so that indicate that there's probably an association with hydrochlorothiazide and risk of skin cancer development. Do not stop your hydrochlorothiazide. Okay, they're just putting it out there. If you had a lot of skin cancers, if that was a major problem for you, it might be a conversation with your cardiologist. The mechanism by which it works is it's probably photosensitizing. It probably makes you more susceptible to sun exposure. All right, this is what squamous cell carcinomas look like under the microscope. Again, nothing you need to know other than it looks different than basal cells. Okay, a lot more pink here, a lot less blue. Now, I wanted to show you a picture quickly of what a squamous cell carcinoma in situ looks like. The ones I showed you before were invasive squamous cell carcinomas, and in this case, we're talking about a really thin, scaly patch. This can also be very, this could be a precancer. In this case, it happens to be a situation in which the top layer of skin is fully occupied by atypical cells. All right. Now, skin cancer treatments. There are lots of skin cancer treatments. We are going to talk about 4 of them. These are the most common 4. And again, we talked before about the fact that it depends on where it is or what the subtype is or what the size is. So I'm going to try and talk you through that a bit. There are topical therapies. There are 2 different types of creams that you can use to treat skin cancers when they are limited to the top layer of skin. So that's that superficial basal cell or the squamous cell carcinoma in situ. Imiquimod is an immunomodulator. It sounds really great. It's a flare to your immune system. You put the cream on, the immune system responds to it, and the immune system comes in to clean up the skin cancer. The downside of imiquimod, as with fluorouracil, is it's probably only about 70-75% effective, even in those superficial skin cancers. And imiquimod specifically can make you feel like you have the flu because you're triggering the immune system. Okay. It's a long course. It's at least 6 weeks of application 5 times a week. So it's a lot, but in patients who want to avoid surgery, it's possible. The other one is fluorouracil. This is usually a 4-week course. It is a directly toxic chemotherapy agent to the atypical cells. So we use this actually not infrequently for treatment of precancers as well, but It can be used for squamous cell carcinoma in situ, which is where it's limited to the top layer of skin. All right. The second one is called electrodesiccation and curettage. We refer to this as a scrape and burn procedure. This is a purely destructive mechanism. You see a skin cancer, you numb it up, you scrape it out, and you cauterize it. And you do that 3 times in the course of about 5 minutes, and it's pretty effective. It, too, has its limitations. It cannot be used in those aggressive forms of skin cancer. It can be used in nodular skin cancers or superficial skin cancers. And cosmetically, it does not look that great. So the likelihood that we would offer that to you on your face, very low. The likelihood we might consider that on your calf or your back, reasonably high, because the cure rates probably come up to about 90%. You do not get evaluation of the margins with that, so it is not the kind of thing that you can be certain is gone. But because the studies are pretty good, you have a pretty good amount of confidence. And if these skin cancers come back, especially ones like that you feel are amenable to electrodesiccation and curettage, you can just cut it out later. Which brings us to option 3, which is a primary excision. Primary excision refers to just cutting a spot out with prescribed margins. So that's when you see a spot, you mark out margins of 4 or 5 millimeters, you cut it out with a football-shaped ellipse, and then you stitch it together. That piece of tissue gets sent out to the pathologist. We call you a week later and say, hey, we got it all, or you know what, we didn't. It's a very good technique. It has 96+% cure rates. It's used widely if we're cutting things out on your back or on your arm or your chest. There are times where it is not the ideal technique, especially if you're on the nose or the ears. But this is something that if you've been if you had skin cancer, you've almost certainly been offered this at some point, and it's a great option. I had a little image about it, but it doesn't seem to have made it onto this set of slides. And the last option is Mohs surgery. So I'm going to talk about Mohs surgery very briefly. You're going to watch this very short video, and then we'll get on to melanomas. But Mohs surgery is a specialized skin cancer removal technique that allows us to check the margins as we go. So I said in a primary excision, we cut it out, we stitch you up, we send you out. With a Mohs surgery technique, we actually are checking as you wait in the office. So in exchange for more time of your day, we get to have 99% cure rates, and we get to know before we stitch you up that the spot is out. Now, this is especially important in that marble analogy or in the infiltrative basal cell analogy, which is that you have these roots that are going out and you can't tell where a spot starts or stops. In those situations, being able to continuously evaluate the margin is very helpful. And Mohs surgery has the benefit of being able to evaluate 100% of the margin, which is not what the pathologist does. I think this video is only about 2 minutes long, so just bear with me here.
Patient comfort is a priority, so before the Mohs surgery procedure begins, the affected area is numbed with a local anesthetic. Then the surgeon excises a saucer-shaped piece of tissue with 1 to 2 millimeter margins around and below the marked border. Hatch marks are made on the skin to maintain specimen orientation. A bandage is placed over the patient's surgical site, and he or she will wait comfortably while the excised tissue is taken to an on-site lab where it's prepared for microscopic evaluation. Many Mohs procedures can be completed in several hours, but some cases will take longer. Your fellowship-trained Mohs surgeon, who has training in skin pathology, carefully examines the tissue under a microscope to see if the cancer has been completely removed. If residual tumor is found, it's marked precisely on the map. A second Mohs layer is excised only in the positive area. This process is repeated until all the margins are free of tumor. Your fellowship-trained Mohs surgeon will explain the most effective means of surgical site closure and post-operative care at the time of your procedure. Small, simple wounds in appropriate areas are allowed to heal naturally by a process known as second intention. Most wounds are closed with a linear repair, a side-to-side stitching of the surgical site. To close a circular wound, extra tissue on either side of the circle is trimmed so that the suture line lies flat. Larger or more complicated wounds may require skin grafts or a flap, which closes the surgical site by moving adjacent looser skin to fill in the wound. There will be some scarring once the area is healed, although scars from Mohs surgery are often smaller and less visible than those from other excision procedures.
All right, we're going to very, very, very briefly talk about precancers because many people who have skin cancers also have a number of precancers. Precancers are called actinic keratoses. They are basically on the pathway to development. These are the kinds of things that if you see your dermatologist, they'll often freeze with some liquid nitrogen. They are not cancers in and of themselves. The potential for these to become skin cancers, again, depending on the study, I usually quote somewhere between 2 and 8%. But if you have lots of precancers, your risk of skin cancer is increased. This is other clinical images of precancers. All right, now we're gonna talk about melanoma. So I hear this all the time when patients come in. I hope I don't have a melanoma, which is true. We don't want you to have a melanoma. But a couple of things I'm gonna try and convey to you is that the vast majority of melanomas diagnosed are very treatable, are unlikely to shorten your life. Additionally, there has been a huge shift over the last 25 years in the treatment of melanoma. So when you talk about melanoma, especially metastatic melanoma that's spread to other parts of your body, if your mindset is from your grandparent who got this in the 1970s, 1980s, 1990s even, it's a very different game now. So back then, even when I was finishing my residency, the only chemotherapy agent used had never been proven to actually benefit melanoma patients, but they didn't have anything else. And in the last 10 to 15 years, there are multiple drugs on the market that has made metastatic melanoma very treatable, and for some patients, not all, a chronic illness rather than a death sentence. So the average metastatic melanoma lifespan, let's say 15 years ago, was about 6 months. There are many cases of people living 10 years or more now on these immunotherapies. So again, that's not everything, that's not everyone, but I want to just put out there that we don't want you to have a melanoma, but melanoma is not necessarily what people think it is. So melanomas are skin cancers made up of melanocytes. If you remember, I said that these are pigment-producing cells. Normal non-cancerous growths of melanocytes are called moles. You have those, that's fine. But a cancerous growth of melanocytes results in a melanoma. One quick thing, we always are looking at your moles to see if they change. We're also looking to see if you have weird new spots. The vast majority of melanomas actually arise de novo, meaning not from pre-existing moles. So I want you guys to be thoughtful of that. It's not always that a mole is changing. It could be a new dark spot. Risk factors pretty similar to what we've talked about before. One thing we'll talk about is that there's a large number of moles or dysplastic nevi, which means atypical moles. That in and of itself increases your risk of having melanoma. The big ones though, family history of melanoma, lots of sunburns at a young age. I'm not sure if I'm beeping or someone else is, but one thing about this slide I want to talk about is the thought that most people have is that if you have dark skin, you cannot develop a melanoma, and it's just not true. So patients of African American descent, Hispanic descent, Native American descent, they do get melanomas. They often get these things called acral melanomas, which can mean melanomas on the hands or on the feet, underneath the toenails. These are bad melanomas to have because they're often ignored because people don't expect to have them. So even though patients of, let's say, African American descent have fewer melanomas, they die at a higher rate from their melanomas than Caucasian patients. This is something many of you have probably seen. Feels like everywhere you go, you learn about the ABCDs of melanoma, and it's what you'd expect. It's asymmetrical, that's bad. The border's not quite right, that's bad. The color is not perfect, that's bad. The diameter is big, that's bad. It seems to be changing, that's bad. This is just one way in which we have people look at their skin. And we're gonna talk through these things here really quickly. I'm gonna show you two pictures here. That first picture on the right, that does not look very good. Has multiple colors. It's really not symmetric. It looks quite large. It's very dark. I have to assume that it's been evolving over time. That is a melanoma, for sure. Now you got this other spot. That also doesn't look that great. That is not very symmetric, maybe. It's got at least two colors to it. It's even raised. It's definitely big. This is a totally benign lesion called a seborrheic keratosis. So the point here is you're going to go home and you're going to say, oh my gosh, Dr. Gogia said if A, B, C, D, and E is there, I need to see Dr. Cobalter immediately. You don't, probably. These are sensitive markers. They're things to get you to think about your skin, to have you come in. The spot over there, the one that's on what I call the anatomic left, but your right as you're looking at it, is a spot that many of you have. You probably have dozens of them. People refer to these as barnacles sometimes. It is really hard to make these distinctions by yourself. I don't expect you to. I just want you to know that not everything that falls under the A, B, C, D, E category is bad. Okay? I'm going to talk again about this in situ versus invasive distinction. In squamous cell carcinomas, this is important. In melanomas, this is everything. In situ melanomas, those that have melanocytes, they're atypical but are limited to the top layer of skin, are stage 0 melanomas. They have essentially no risk of spreading elsewhere. Okay? So they're saying horizontal growth within the epidermis is a melanoma. In situ, vertical growth, if it breaks through that into that second layer, you now have an invasive melanoma. And if it breaks through, it can spread. But I want you to look at that bottom line, because this is the game. Prognosis is closely related to the depth of invasion. How far into the second layer of skin is your melanoma going? Anything less than 1 millimeter, which is the vast majority of what we diagnose, is considered a thin melanoma and has exceptionally good cure rates just with an in-office surgery. Okay? Anything greater than 4 millimeters, which we very rarely diagnose, that has a bad prognosis. And then there's an intermediate thickness that does so-so. Again, this goes to this idea that not all melanomas are the same, not all melanomas are death sentences. Most of the time when I call patients with the diagnosis of a melanoma, I spend my time trying to tell them that although it's got a terrible connotation, melanomas are very treatable for the most part. All right, so what do we do to treat melanomas? The primary way we treat it is with surgical excision. Most people, especially those with thin melanomas, just get an in-office surgery. It's a really long scar because we got to take a really big margin, but it's fine. They do really well. We cut it out, we send it out to the lab. Cure rates are very, very, very good for thin melanomas. If you have a slightly thicker melanoma, we'll sometimes send you to get a sentinel node biopsy. A sentinel node biopsy is where the surgeon injects a little bit of a dye into the skin at the site of the melanoma and sees where it drains to, and then it goes and takes out 1 or 2 of those nodes. That's just to see if the melanoma has already spread to the lymph nodes, which is the most common place that it will go. Most people do not require a sentinel node biopsy, okay? So if you had a melanoma, you didn't have one, it meant you probably had a thin melanoma. I'm going to put this up here because if you Google it, you're going to see there are now gene expression tests that can go and look at how the melanoma or what genes the melanoma is expressing, and it gives you some insight into how aggressive it might behave. It has not really taken off, I would say. It's being used more, but it's not being used as widely. And then let's say you had a metastatic melanoma. It's already spread to other parts of your body. I just told you that all sorts of things have come up to help you, and there's 2 main categories. One's called targeted therapies, the other one's called immunotherapy. I'm not going to get into this at length, but I'm going to give you very quick breakdowns. If you think about these pathways of cell growth that I talked about before that have gone haywire because they continue to allow these cells to grow, targeted therapies go and hit those growth pathways and stop them. They just put a break in it. Now, the body's really smart, so the problem ends up being that you use a targeted therapy, you shrink your tumor down by 90%, everyone's cheering, it's amazing, and then a year later, the melanoma cell has figured out a way around that checkpoint inhibitor. So most of the time with targeted therapies, you'll use multiple different targets, or you'll start with targeted therapies and add on immunotherapy. Okay. Immunotherapy is basically where the world is right now, and it's amazing. It's used in all sorts of cancers, not just skin cancer. It is probably going to generate like 10 Nobel Prizes. I think it already generated 1. It is an unbelievable way of harnessing the immune system to kill cancer. So the way this works is that the immune system surveils the skin looking for atypical cells. We know that already from earlier. But sometimes the skin cancer cell can go up to an immune cell and say, hey, you know what? Just chill out for a little bit. I don't need you to work on this right now. We're good. And the immune system says, okay, cool. Like, I'm going to just hang out here while my melanoma continues to grow. That doesn't seem like a great idea. So what happens with immunotherapy is one of 2 things. It either goes and says to the immune cell, don't talk to the melanoma cell, just do your job. basically blocks the connection that was shutting it down. Or it totally removes the brake from the immune system overall. So the immune system has all sorts of things to keep from autoimmunity. You don't want to attack yourself. There's all sorts of checkpoints that we try and keep ourselves from attacking ourselves. And immunotherapy says, nope, all bets are off. You've got a metastatic melanoma, go to town. And it is really remarkable what immunotherapy can do. If you haven't heard about it, you will, not just in this, but in lung cancer and in brain cancer and all sorts of other things. All right, this I put in solely because of Jimmy Buffett. I got asked a lot of questions about Merkel cell carcinoma. Merkel cell carcinoma is super rare. There were 2,000 cases diagnosed last year, as opposed to the more than 2 million of the other types of skin cancer that we talked about. These look like a whole lot of nothing. They can be painless. They're usually lumps on sun-exposed skin. The major risk factors here for sure are age, sun exposure, and something called a Merkel cell polyoma virus. So I would spend exactly 0 time worrying about a Merkel cell. Okay, I think in my practice, in my career, I've diagnosed 3 of them, maybe 4. I mean, it happens, but it's not very common. The problem with Merkel cell is that people do not do very well. So everyone is worried about melanoma, understandably. Merkel cell is a worse cancer on average. Just because it's interesting, I said there were 3 things that can cause it. Sun exposure and age go together, of course. The average age at diagnosis is 75 to 80. It's almost exclusively Caucasian in sun-exposed areas. It can definitely happen in other patient populations, but Caucasians, Northern Europeans get it more. And then the thing about the virus that's interesting is the virus itself is very common. If we tested any of you for the virus, you might have it. It's not sufficient. Having the virus is not enough to have a cancer. But if you look at these, and you can, in about 80% of cases, you can actually see the virus particles there. That turns out to be really nice for Merkel cell. It's a new thing because you can actually test the blood for antibodies to Merkel cell and actually see how much of an immune response you're getting. If you have a big immune response, you actually end up doing better. Okay. Again, I would spend 0% of the time. This would not have been in the talk if Jimmy Buffett had not just died of it. All right. I'll try and get through the last of this pretty quickly, guys. So prevention. I know that's what people want to hear about. I think the problem with prevention is that a lot of times when I tell you this, you're saying, so the answer is I need to go tell my mom 55 years ago that she should have put sunscreen on me. And that is most of what the next 2 slides are. Basically, try to avoid getting burned. Try to avoid a lot of sun exposure. Both UVA and UVB rays are problematic. Intentional tanning is really bad. I am probably the most liberal dermatologist I know. I think it's great for you to go out for a run. I want you to wear sunscreen. I want you to wear sun protective clothing. But I think there are benefits to being outside. I just want you to do it in the best possible way. You're going to generously apply sunscreen at SPF of at least 30. It lasts for maybe 2 hours, so you're going to reapply it. I think sun protective clothing is amazing. You can get it at REI or any store. It has an SPF usually of 50 in it. They come in nice long sleeve shirts. They come in pants. It allows you to be outside a little bit more liberally without worrying about continuously reapplying. Do not let perfection be the enemy of good. What I hear all the time is, I can't reapply this, so I'm not going to put any sunscreen on. Put sunscreen next to your toothpaste. Use it every morning. Start to develop a habit. You'll be amazed how often you are out in the sun more than you think. So I talk to my teenage patients and I tell them this. I say, think of it like your toothpaste. You brush your teeth because you're going out for the day, not because you're meeting 5 friends instead of 2 friends. If you make cognitive decisions about your sun exposure, you're going to be wrong. And just try that. Tomorrow be like, oh, I'm not going to be out in the sun that much. And it's going to be 85 degrees and you're going to get caught on a walk and it's going to be just an unbelievable amount of sun exposure. All right. I said that everything was about going back in time. There's not everything. So there are a couple of things that you can still do. The first one's called field treatment. We talked a little bit about imiquimod and fluorouracil. If you have a lot of precancers, you can treat them with creams or with a blue light therapy that's going to decrease the number of precancers and therefore decrease some of your non-melanoma skin cancer development. These things make you look really red and rashy and scabby. I know some of you have had it. I know some of you have heard about it. It is a great option for the patient who needs it, and it can definitely decrease your skin cancer development without going back in time. The last thing I'm going to talk about as far as prevention goes is actually this study that came out 7 years ago maybe that gives you a way of preventing skin cancers via vitamins. So this paper came out and it says that if you take 500 milligrams of vitamin B3 twice a day, you can decrease your risk of skin cancer by about 23%. So it's a pretty amazing study because it's a easily available vitamin. It has no real side effects for most people. But a couple of downsides to this is that the effect only lasts as long as you're taking it. Okay, so if you take it for a year and then you stop, you're right back to where you were. And the real problem ends up being, or at least I should say, how I think about this is, let's say we call it a 25% risk reduction. If you're a person who develops one skin cancer a year, you have to take the pills for 4 years to prevent one skin cancer. That's 2 pills a day, 365 days a year for 4 years. That is a lot of pills. These are very treatable skin cancers. It doesn't mean that you shouldn't take it. But my patient population, honestly, and I see a lot of skin cancer, I offer this to patients who develop multiple skin cancers in a year. If you're developing 4 or 6 skin cancers in a year, you should be on this medication. It's a conversation to have with your dermatologist if you'd like, but just know there are things you can do. It's not all about going back in time. The other prevention point, obviously, is just to take a look at your skin. All I want you to learn from this is take a look, be thoughtful, and then use some common sense. So I have patients who come in all the time, and they say they got a spot on their nose, but it's just a pimple. And I say, well, how long has the pimple been there? And they say 2 years. And most pimples don't last 2 years. It's okay. People do this all the time. They often write things off. I get it. But this is what I want you to take away from it, is if it looks kind of weird, even if it just looks like a pimple, but it's been there for a really long time, maybe get it checked out. We can take a look at it. These things are slow growing. You haven't done yourself any harm. There's no judgment. We just want to make sure we get you to where you want to be. And this is how to look at your skin. But honestly, if you have someone who can look at it for you, that's great. There's evidence that patients in long-term relationships do better from melanomas because their partner forces them to get seen. And then if you notice anything different, so if you see an ugly duckling, a spot that doesn't look like your other spots, or spots that are really red and scaly, spots that are tender, those that are growing quickly, you'd want to get that checked out. One of the most common things I see in the facial skin cancers, if you wash your face every morning and a spot bleeds on your nose, that's not normal. So, come get it checked out. So things that don't quite heal, these are the kinds of things you should be looking out for. But if you do need us, we're here. We're in Novato. We're in San Rafael. We closed our office that was just down the road from here. I think some of you guys know that. But we are very, very happy to see you. We really all love seeing patients. We really enjoy patient care. We are a practice that is very dedicated to medical and surgical dermatology. I'm certain that outside of the fact that it's a little bit challenging to get an appointment these days, we would be happy to see you. I think that's it. I really appreciate your guys' time. Thank you so much.